Okay, it's time to talk about lymphomas. We're just going to read through a case, look at a few pictures, and basically just going to read the case, nothing fancy. So let's start. Lymphomas. First, the case presentation. A 66-year-old male has inguinal, axillary, and cervical lymphadenopathy. The nodes are firm and non-tender to palpation. A biopsy of a cervical node shows a histologic pattern of nodular aggregates of small, cleaved, indented lymphoid cells and larger cells with open nuclear chromatin and several nucleoli. A bone marrow biopsy shows aggregates of lymphoid cells like that in the lymph nodes with surface antigens that are CD10 plus and CD5 negative. Karyotyping of these lymphoid cells discloses a 14-18 translocation. What is the diagnosis and how should he be treated? So continuing on with an introduction to B-cell lymphomas. Hodgkin's lymphoma is a neoplasm derived from the B-cell lineage with distinctive histologic Reed-Sternberg cells, molecular, immunophenotypic, and clinical features. Classical Hodgkin's lymphoma, which accounts for 95% of cases of HL, is divided into four subcategories: nodular sclerosis, 60%, mixed cellularity, 30%, lymphocyte depletion, and lymphocyte-rich HL. With an incidence of approximately 3 cases out of 100,000 a year, approximately 7,400 new cases will be diagnosed in the US annually. HL is important historically because it showed that a strategy involving a combination of multi-agent chemotherapy and/or irradiation could achieve cure rates of greater than 80%. Recognition of late complications following radiation therapy, including breast cancer and heart disease, underscore the adverse effects in a disease that has a peak incidence at 25 to 30 years of age, with another smaller peak after 60 years of age, thus it is bimodal. Another milestone in oncology was the amassing of evidence to show that Epstein-Barr virus, EBV, is a contributory factor in the development of HL. Such evidence includes demonstrating the presence of the EBV genome in the RS cell in situ hybridization in approximately 40% of patients, further supporting the association of EBV with HL. A history of infectious mononucleosis increases the risk of HL threefold, a vulnerability that persists for several years. In addition, a genetic contribution is suggested by a 7-fold increase when a sibling is diagnosed with HL. Because siblings often share a similar environment, this could also support common exposure to an environmental pathogen such as EBV. Now let's talk about the maturation of normal cells. It is worthwhile reviewing development of normal B cells in contrast to the loss of B cell in phenotype in the giant RS cells, which are characteristic of HL. These Hodgkin and Reed-Sternberg cells represent no more than 1 to 5% of the cells found in an open excisional biopsy lymph node specimen. When antigen binds to the B cell receptor, BCR, of a mature B cell, and that B cell also receives co-stimulation by a T helper cell, usually through CD40, the B cells migrate from the bone marrow to B cell follicles in lymph nodes and the spleen. This initiates an intense proliferative response with vigorous cell replication, leading to the formation of germinal centers. In the germinal centers, the B cells undergo a process called somatic hypermutation, in which mutations in the variable or antigen binding domains often occur, creating variants of the BCR, some of which may confer increased affinity for the antigen. Such cells will be positively selected. However, many mutations will be deleterious, encoding premature stop codons or nonsense mutations, a change in reading frame, or diminished affinity for the complementary antigen. Cells harboring these deleterious mutations would normally undergo apoptosis and be disposed of by macrophages. In HL, there is evidence that HRS cells are derived from B cells in the proliferating germinal centers that bear deleterious mutations but do not undergo apoptosis as with normal cells. It thus appears that HR cells have acquired mutations or a latent EBV infection that causes the cells to become immortalized and escape apoptosis instead of appropriately undergoing apoptosis when they carry nonsense or other crippling mutations. HRS cells are set apart from B-cell lymphomas and leukemias because HR cells no longer display evidence of their B-cell origin. Thus, HR cells do not express the usual B lymphocyte markers such as CD19, CD20, and CD22. By comprehensive gene expression profiling using DNA chip microarrays or serial analysis of gene expression or SAGE techniques, it has been shown that RNA expression of nearly all genes specific for B cells are either absent or profoundly diminished in HR cells. In addition, there is evidence that HR cells have lost BCR expression, or the B cell receptor expression, and that the signal transduction machinery that is coupled to BCR binding of antigen. Germinal center B cells without a functional BCR complex normally should undergo apoptosis. The fact that HRS cells are able to escape apoptosis is believed to be a factor contributing to the CHL tumor formation or classical Hodgkin's lymphoma formation. It is believed that the loss of expression of these B lymphocyte genes is the result of reprogramming of HRS cells because multiple transcription factors, including OCT2, BOB1, and PUI, are downregulated. And I remember those by thinking about October the 2nd, BOB1, and DUI or PUI are downregulated. When one adds to this the finding that HRS cells show some expression of genes found on T cells and dendritic cells, one can appreciate the profound disruption to normal expression of transcription factors that should permit the B phenotype to develop. The cause of this reprogramming is under investigation. One of the factors thought to participate is the nuclear factor Kb. So let's talk a little bit about nuclear factor Kb. Nuclear factor, or NF-Kb, and survival of HRS cells. NF-Kb are a family of transcription factors discovered in 1986 that have been shown to play a key role in regulating inducible gene transcription in multiple mammalian cell types and are intimately involved in inflammatory responses and cell fate decisions as well. As expected, activation of such powerful transcription factors would be under tight control to assure that the effect is transient. But in HRS cells, NF-Kb is expressed constitutively, causing the signal it transmits to persist. Among the effects of NF-Kb is obstruction of programmed cell death. How can NF-Kb be turned on in HRS cells? Tumor necrosis factor receptors are overexpressed in HRS cells, including CD40, and receptor activator of NF-Kb, RANK. the latter of which has been shown to figure prominently in bone homeostasis. The increased expression of tissue necrosis factor receptors converts NF-κB expression from transient to constitutive. Further, amplified expression of REL, or REL, a member of the NF-κB family, has been demonstrated in almost 50% of cases of CHL. Okay, next we're going to talk about the JAK-STAT signaling pathway. The JAK-STAT signaling pathway is central to the transmission of signals from cytokines, and these cytokines are interleukin 5, interleukin 6, interleukin 9, and interleukin 13. They are upregulated in HRS cells because cytokines are powerful animators of cell proliferation. This is believed to contribute further to proliferation and resistance to apoptosis of HRS cells. Taken together, a number of proliferative signals are expressed constitutively or deregulated in HRS cells. Now let's turn to talking about the role of Epstein-Barr virus in Hodgkin's lymphoma. Epstein-Barr virus, or EBV, is a member of the gamma herpes virus family and was the first virus shown to be present in transformed cells, in this case cultured lymphoblasts from Burkitt lymphoma, or BL, a variant of non-Hodgkin's lymphoma. Subsequently, it has been shown that approximately 40% of cases of CHL harbor EBV, especially cases of mixed cellularity and lymphocyte depleted HL. It is well known that EBV is the causative agent of infectious mononucleosis and that 90% of the world's population is seropositive for EBV. Latently infected EBV and HRS cells express three viral proteins: EBNA1, LMP1, and 2. Epstein-Barr nuclear antigen EBNA1 is essential for B cell immortalization. It helps replicate the viral genome and promotes degradation of p53. Latent membrane protein LMP1 can mimic the signal provided by CD40 from T cells, thus acting as a constitutively active receptor for stimulating expression of the NF-κB and JAK-STAT signaling pathways. Thus, LMP functions as an oncogene. LMP2, while not essential for B cell immortalization, blocks normal B cell development. LMP2 has been shown to replace the function of B cell receptor BCR, thus permitting B cells devoid of a BCR to avoid apoptosis. Now let's move on to talk about the role of the cellular microenvironment on persistence of HRS cells. The cells present in classical Hodgkin's lymphoma, or CHL, tumor tissues are a variety of inflammatory cells, including T cells, B cells, plasma cells, neutrophils, eosinophils, and mast cells, which together are so numerous that HRS cells account for only 1 to 5% of the cells in neoplastic growth. Several cytokines, interleukin 4, interleukin 6, 7, 9, 13, and 15, secreted by HRS cells, attract the above swarm of cells into the HL microenvironment, and the paracrine signals secreted by these infiltrating cells promote survival of the HRS cells. Thus, it is now widely held that these infiltrating cells are an integral part of the pathogenesis of HL, acting not only to promote HRS cell growth, but also to block innate and acquired immune surveillance of these cells. The cytokines noted above are believed to be responsible for the fever, weight loss, and night sweats that occur in approximately 30% of patients with CHL. Now we will discuss the pathology of classical Hodgkin's lymphoma. Because HRS cells usually comprise no more than 1 to 5% of the cells in the tumor, an open biopsy is required for diagnosis. The HRS cell is renowned as a large cell with a diameter of 15 to 45 micrometers, with a single nucleus with 2 or more lobes, or several nuclei and an eosinophilic nucleolus. Further, the cells surrounding the HRS cells, and which greatly outnumber the HRS cells, include small lymphocytes, T and B, neutrophils, eosinophils, plasma cells, and macrophages and mast cells. There are 4 morphologic types of classical Hodgkin's lymphoma. Number 1, nodular sclerosis, which accounts for 60 to 65% of patients with CHL in Western countries. Nodular sclerosis, which is characterized by broad bands of collagen and so-called lacunar cells, which are variants of RS cells. Let me read that again. So nodular sclerosis accounts for 60 to 65% of patients with CHL in Western countries. Nodular sclerosis is characterized by broad bands of collagen and so-called lacunar cells, which are variants of RS cells. Second, the mixed cellularity type accounts for approximately 30% of cases and is more common in immunodeficient individuals, the elderly, and patients from developing nations. HRS cells are more numerous in this variant than the other 3 types, and fibrosis is absent. So once again, mixed cellularity type accounts for approximately 30% of cases and is more common in immunodeficient individuals, the elderly, and patients from developing nations. HRS cells are more numerous in this variant than the other 3 types, and fibrosis is absent. There is a polymorphic infiltrate of eosinophils, plasma cells, histiocytes, and RS cells, and EBV has been found in 70% of the cases of mixed cellularity. 3. The lymphocyte depleted type. This is rare, manifesting with fever, lymphocytes, and many RS cells. There is no association with EBV. Okay, so this slide we're looking at is actually lymphocyte depleted. A moment ago I put the wrong slide up of non-Hodgkin's lymphoma, so don't get confused here. We are looking here at mixed cellularity Hodgkin's lymphoma. Okay, I'm going crazy here. That is definitely not mixed cellularity. This is lymphocyte depleted Hodgkin's lymphoma. The lymphocyte depleted type is rare, manifesting with fewer lymphocytes and many RS cells. There is no association with EBV, and this form has the poorest prognosis. The lymphocyte rich type is a relatively recently described form that is moderately aggressive, and 40% of cases here have evidence of EBV that has been demonstrated. So I'm going to try and find a case of that right now. So this is an example of lymphocyte-rich Hodgkin's lymphoma. So what can we say about lymphocyte-rich? Older men, it has good prognosis. A few other things, we'll talk about that later, I guess. So moving on, we're going to talk a little bit about the clinical manifestations. HL usually presents with adenopathy above the diaphragm, especially in the lower neck and supraclavicular nodes. The abnormal nodes are rubber-like in consistency and are usually painless. An open biopsy is necessary for diagnosis. A clue to the diagnosis of CHL is the rapid onset of pain in affected lymph nodes with alcohol consumption, something found in many patients. The reason for this is not known. Some patients present with cough or even difficulty breathing because of large mediastinal lymph nodes involved with lymphoma. Approximately 30% of patients have fever, weight loss, and night sweats without prominent adenopathy, which are referred to as type B symptoms of HL. A rare but useful symptom is unexplained pruritus. Immunodeficiency patients and the elderly are more likely to have B symptoms and a mixed cellularity histopathologic pattern. So let's move on. We're going to talk about evaluating a patient with Hodgkin's lymphoma. Once the histopathologic diagnosis of HL has been made, it is essential to determine the extent of the disease. Typically, HL spreads to contiguous nodes. When HL disseminates more widely, it does so to only 4 organs, and those 4 organs are the spleen, the bone and bone marrow, the liver, and the lung. Once again, the spleen, the bone and bone marrow, the liver, and the lung. The physical examination should evaluate lymph nodes throughout the body with special attention to those in the neck and upper thorax. Evidence of organomegaly should be sought. Laboratory evaluation includes CBC with differential liver function tests and renal function tests. If warranted by history or histology, testing for HIV should be performed. Because of advances in CT and PET scanning, staging laparotomies are no longer performed or needed. Now, staging using the Ann Arbor system depends on the extent of lymph node and disseminated disease. Stage 1 involves 1 nodal area. Stage 2 involves 2 or more nodal areas on one side of the diaphragm. And stage 3 involves nodal areas on both sides of the diaphragm. Stage 4 is disseminated disease involving 1 or more extranodal sites. Now a little bit about the prognosis of Hodgkin's lymphoma. With advances in diagnosis and treatment, 80% of patients with HL can be cured, whether stage 1 or 2. Unfortunately, advanced stage or age over 65 years is not associated with as bright a prognosis, especially because the elderly cannot withstand the rigors of a full chemotherapeutic regimen. Okay, now let's talk about therapy for HL. The most effective therapy is a combination of doxorubicin, bleomycin, vinblastine, and dacarbazine, the so-called ABVD regimen, which is administered in 4 cycles. Doxorubicin is an anthracycline antibiotic that acts through 4 mechanisms to kill cancer cells. Specifically, doxorubicin inhibits topoisomerase II, an enzyme involved in relaxing supercoiled DNA, binds to DNA intercalating between bases in DNA and blocking the synthesis of DNA and RNA, binds to cell membranes and interferes with iron transport, and generates reactive oxygen species. This last action accounts for the cardiotoxicity of doxorubicin. So can you see doxorubicin in this picture? So here it is, doxorubicin, and remember it was called ABVD regimen, so they're talking here about adriamycin here, so don't get confused. Here it says doxorubicin. So that is the A right here. And the cardiotoxicity is something you have to worry about. Next, bleomycin. Bleomycin is a small peptide that binds to DNA causing breaks in the DNA helix and thereby inhibiting DNA replication. Bleomycin is a cell cycle specific drug causing cells to aggregate in the G2 phase of the cell cycle. Bleomycin is not used for the treatment of HL, is not only used for the treatment of HL, but also to treat non-Hodgkin's lymphoma. The major toxicity associated with bleomycin is pneumonitis, manifested as cough, dyspnea, and infiltrates on chest X-ray or pulmonary fibrosis. And this can culminate in pulmonary fibrosis. So there we have. So far we have adriamycin or doxorubicin and now bleomycin. Okay, next in this ABVD regimen we have vinblastine. And vinblastine is an alkaloid derived from the periwinkle plant that causes depolymerization of microtubules, thereby interfering with the cell's ability to undergo mitosis and cell division. Besides nausea and vomiting, the major toxicity of vinblastine is myelosuppression. Also, I'm pretty sure peripheral neuropathy is something you have to worry about. So on to D. D is dacarbazine, and dacarbazine acts as an alkylating agent, transferring an alkyl side chain to DNA and negatively charged groups or nucleophiles on proteins. The preferred side of DNA is the N7 position of guanine, if you can remember that. Okay, well now we'll talk about Hodgkin's lymphoma and pregnancy. Recalling that the first peak of HL presentation is at about 25 years of age, it is not unexpected that some pregnant women will be shown to have HL. Management calls for special expertise, but if the pregnancy cannot go to term without chemotherapy, administration of vinblastine alone has shown to be effective, with the important advantage that it is not teratogenic. And there are some late complications of treatment of Hodgkin's lymphoma. Because irradiation has been shown to be associated with late complications in greater than 10 years after successful cure of HL, irradiation is now employed in a more targeted fashion, or in some instances is avoided altogether. In the past, complications of irradiation included hypothyroidism, including occurring in approximately 1/2 of patients receiving neck irradiation. Breast and lung cancer are also late complications of irradiation. So to recap there, some complications of irradiation, here are 3: hypothyroidism, breast and lung cancer. Regarding the alkylating agents, they have been associated with the development of male and female infertility and premature menopause in women. And coronary artery disease is a long-term risk from irradiation, and cardiomyopathy from excessive doses of doxorubicin, as was stated above. Okay, now we're looking at the correct slide. We're looking at non-Hodgkin's lymphoma, and here we're looking at small lymphocytic mantle cell, Burkitt's, lymphoblastic follicular cell center, large B cell, and peripheral T cell. These are all non-Hodgkin lymphomas. The non-Hodgkin's lymphomas, or NHLs, represent as a large group of heterogeneous neoplastic disorders of the lymphoid system arising from B cells, about 85%, or T cells, 15%. These neoplasms stem from cells at various stages of differentiation of the lymphoid cell lines, and NHL differs from HL primarily in retaining features of the cell line from which they arose, setting them apart from the unique and distinctive HRS cell that has the hallmark of several HL variants. In addition, NHLs harbor translocations of immunoglobulin heavy chains IgH on chromosome 14 to oncogene sites, contributing to increased proliferation of survival of cells. Such translocations are uncommon in Hodgkin's lymphoma, and recall that class switch recombination and somatic hypermutation involve the IgH locus, as in Burkitt lymphoma, and this has an 8-14 translocation. These translocations in NHL, while contributing to neoplastic transformation, must be supplemented with other genetic mutations as in other tumors for the malignant phenotype to emerge. Like HL, NHL usually presents with lymphadenopathy, typically of peripheral nodes in contrast to HL. Extranodal spread is common with the NHLs. Production of pro-inflammatory cytokines may trigger constitutional symptoms, including fever, weight loss, and night sweats. Treatment has generally improved the prospects of patients, extending life and sometimes effecting a cure. NHLs are among the most common malignancies affecting both men and women, and there is troubling evidence that the incidence of this group of malignancies is increasing, while the incidence of HL remains stable. In the United States, the incidence of NHL is 19 per 1,000 per year. This translates to greater than 60,000 new cases per year in the US. And one factor contributing to the rise in the number of NHL cases is HIV infection. So now let's talk about the etiology of non-Hodgkin's lymphoma. First, key associations between autoimmune conditions, immunodeficiencies, viruses, bacteria, and environmental exposure have been detected in the causation of specific NHLs. For example, there is an increased incidence of lymphoma in Sjogren's syndrome and rheumatoid arthritis, suggesting that persistent immune stimulation and its expected effect on somatic hypermutation predisposes to genetic damage in developing lymphocytes. Another example of chronic immune stimulation is Helicobacter pylori infection of gastric mucosa and the development of mucosal associated lymphoid tissue, or MOLT lymphoma, one of the variants of NHL. Notably, MOLT can be successfully treated with antibiotics, which eradicate the bacterial infection. So here's a picture of MOLT lymphoma. There is abundant circumstantial evidence for a role of viruses in causation of lymphoid tumors. Some viruses may integrate into the host genome, while others may drive proliferation. There is evidence for EBV in causing NHL in immunodeficient patients and in post-transplant lymphoproliferative disease, or PLTD. The most well-known role for EBV in the most well-known role for EBV in lymphomagenesis is in Burkitt lymphoma, in which infections with EBV occur in 95% of endemic African cases. Human T-cell leukemia, or lymphoma virus, HTLV, has been shown to participate in the development of adult T-cell leukemia/lymphoma. And the Kaposi sarcoma virus, human herpes virus, or HHV8, has been associated with a rare B-cell lymphoma, primary effusion lymphoma, arising in patients with AIDS. And one more thing, exposure to pesticides containing organochlorine components has been associated with the development of NHL. So remember those organochlorine components for the association with the development of NHL. So now we'll talk a little bit about the classification As noted, HL is defined by the presence of HR cells, and consequently all other lymphomas fall into the category of NHL. The most recent classification of NHL by the World Health Organization divides lymphomas between B cell and T cell / NK cell neoplasms. So firstly, the most common type is diffuse large B cell lymphoma. So I'll try and find that. So here we are looking at diffuse large B cell lymphoma, which accounts for approximately 30% of NHLs. The next one is follicular lymphoma. And so you might remember this from the case study introduction. This is follicular lymphoma, which accounts for approximately 20% of cases of NHL. And another group of less common lymphomas, which each accounting for 5 to 10% of all NHLs, include extranodal marginal zone MALT lymphomas, which we saw earlier. And then there is the peripheral T cell lymphomas. So let me give you a look at that. We're looking here at a T cell lymphoma. And then there is the small lymphocyte lymphoma. This is small lymphocyte lymphoma, and also mantle cell lymphoma. Here we can see mantle cell lymphoma. So while Burkitt's lymphoma is quite rare in Western countries, it is common in Africa among children. So remember that. Now this is Burkitt's lymphoma. We're going to talk a little bit more about that later, I think. But this is the Burkitt lymphoma with the famous starry sky experience, starry sky appearance. You can see the macrophages that are gobbling up the broken up pieces. There may be viruses, there may be pieces of the what's been eaten up, but this is the typical image of Burkitt's lymphoma. So next we're going to talk about molecular genetics and other studies. Immunophenotyping using CD markers for B cells is important in the accurate classification of NHLs. Especially important has been the identification of signature translocations by cytogenic techniques. For example, the genetic hallmark of follicular lymphoma. So I think this is what we're looking at, the genetic hallmark follicular lymphoma. So here we have an example of immunophenotyping of follicular lymphoma, if I'm not mistaken. And this is the second most common NHL and most common of the slow-growing lymphomas. It is the 1418 translocation with rearrangement of the BCL2 gene. This translocation brings about inhibition of apoptosis by BCL2. So remember, follicular lymphoma 1418 and the BCL-2 translocation. Now talking about DLBCL, or diffuse large cell lymphoma, this is the most common NHL in Western countries. This category contains several diseases with variable presentations, natural histories, and molecular profiles. The most common genetic defect in DLBCL is rearrangement of the BCL6 gene on chromosome 3. So that's easy to forget. This is BCL6 gene on chromosome 3 with various translocation partners causing promoter substitution with inconsistent expression of BCL6. Indeed, BCL6 is a transcription repressor of expression of various genes, including cyclins, which are involved in the cell cycle, and TP53, which protects the integrity of the genome. In lymphoid tissue, BCL6 is important for germinal cell formation, and blocking its action may interfere with complete differentiation of B cells. Another consequence may be blocking apoptosis, which normally would occur in the face of DNA damage within a transformed cell. As a third example, Burkitt's lymphoma is an aggressive, fast-growing tumor. It is characterized by a translocation of 814 and involves a MYC on chromosome 8 and an immunoglobulin chain on chromosome 14 in 80% of the cases. So remember that immunoglobulin chain on chromosome 14. In fact, CMYC is an oncogene that regulates numerous genes involved in proliferation, differentiation, and apoptosis, which as a result of the translocation is now overexpressed because it is driven by enhancer elements controlling immunoglobulin synthesis, a process that is the center of the life of a B cell. Now let's talk about some of the clinical manifestations of NHL. Like HL, the common presentation of NHL is painless lymphadenopathy in the cervical, axillary, or inguinal regions. When lymph nodes are enlarged in the mediastinum or abdomen, symptoms may include cough, chest pain, superior vena cava syndrome, which is congestion of the face and dilation of collateral veins of the upper thorax and neck, abdominal pain and back pain with or without spinal compression. Fevers, night sweats, and unexplained weight loss, likely secondary to cytokine secretion, also may be presenting complaints. We're looking at a picture here of superior vena cava syndrome. There's another picture. So now we'll talk about the diagnosis of non-Hodgkin's lymphoma. An excisional biopsy of an affected node is necessary for accurate diagnosis. Staging using the Ann Arbor system employed for HL is necessary to determine the treatment protocol. Staging is usually accomplished by CT and PET scans. However, a bone marrow biopsy may be needed. Laboratory tests include a CBC, serum electrolytes, uric acid, LDH, liver function tests, and HIV and hepatitis serologies. Tests for HTLV and EBV are indicated with PLTD, post-transplant lymphoproliferative disorder, which is a transplant complication, and nasal lymphoma. Okay, now we're going to move on to talk about the therapy of the lymphomas. First, we're going to talk about for follicular lymphoma. Okay, in this slide, we're looking at disseminated follicular lymphoma. Most patients with FL present after 60 years of age with painless peripheral adenopathy. Constitutional symptoms only occur in minority of patients, except for bone marrow involvement, which is approximately 60% of patients. Other organs are rarely affected in follicular lymphoma laboratory findings. The laboratory findings include anemia, increased LDH, and neutropenia and thrombocytopenia because of bone marrow and splenic infiltration. Just find a good image here. And moving on, talking about follicular lymphoma. So I was saying laboratory findings include anemia, increased LDH, and neutropenia and thrombocytopenia because of bone marrow and splenic infiltration. At diagnosis, most patients are stage 3, lymph node involvement on both sides of the diaphragm, above and below, or stage 4 involvement of one or more extra lymphatic organs. Until the advent of rituximab, a chimeric anti-CD20 monoclonal antibody, many centers have adopted a policy of watchful waiting until patients develop symptoms. However, rituximab has thrown into question this passive approach to therapy. In fact, the use of rituximab with conventional chemotherapy is being investigated in clinical trials to ascertain the best approach, because almost all patients relapse after therapy. Nevertheless, even before rituximab, some patients survive for 10 years, and 40% of these patients were at least 70 years of age when first diagnosed. Now let's talk about diffuse large cell lymphoma. DLBCL, or diffuse large B-cell lymphoma, is an aggressive NHL and is the most common lymphoma in Western countries. Rates of NHL continue to increase and are likely attributable to immunosuppression, AIDS and transplantation, and pesticides. Cells in DLBCL have the appearance of germinal center lymphoblasts, which are larger than mature lymphocytes. Until rituximab, patients with early cell DLBCL, in which disease is confined to one side of the diaphragm, were treated with chemotherapy and subsequent irradiation of the involved field. But now with rituximab, progression-free survival of 88% has been achieved at 4 years, representing a dramatic improvement in short-term outcome. Treatment with rituximab and cyclophosphamide, adriamycin, vincristine, and prednisone, or CHOP, for patients with disseminated DLBCL has achieved results superior to those with CHOP alone. I'm going to try and find some picture of CHOP. Well, I did find this picture for DLBCL treatment. Initial therapy, it shows R-CHOP, so I guess that's rituximab plus CHOP. So remember, the CHOP here is cyclophosphamide, which is the C, and H stands for hydroxydanurubicin. Alright, I'm just trying to find some pictures here to show what CHOP is. Anyway, CHOP, cyclophosphamide, doxorubicin or danurubicin, or hydroxydanurubicin. There you go. Vincristine and prednisone. So that's CHOP, which is used, often used with rituximab for non-Hodgkin's lymphoma. So here we are again looking back at Burkitt lymphoma. BL is lymphoma that occurs in the first 2 decades of life, and while it accounts for only 2% of lymphomas, discoveries about the molecular genetics role of EBV, or the Epstein-Barr virus, and the fact that it is a pediatric disease have driven research on this tumor. BL is a rapidly growing invasive tumor with a high rate of spontaneous apoptosis, which produces cellular debris that is ingested by macrophages, which with their abundant clear cytoplasm look like starry sky against the deeply staining tumor cells. Endemic BL is concentrated in equatorial Africa and is characterized by jaw and facial bone disease and is associated with latent EBV infection. Because BL proliferates so rapidly, with a doubling time of 48 hours, it has been treated with dose-intensive regimens and short cycles to curtail tumor growth. Rituximab is being added to these regimens. Clinical trials will determine whether or not this is a more efficacious approach. Okay, now we will talk about AIDS-related lymphoma. In patients with AIDS, the incidence of NHL is increasing 100-fold, but the incidence of primary CNS lymphoma is increased 3,600-fold, and immuno immunodeficiency-associated Burkitt's lymphoma is increased 1,000-fold. Several factors conspire in the pathogenesis of AIDS-related lymphoma and include the profound CD4 cell deficiency, chronic antigenic stimulation, co-infection with EBV and Kaposi sarcoma herpes virus, and cytokine dysregulation. With this constellation of forces acting against normal lymphocyte function, it is not surprising that lymphoma is a consequence of AIDS. So back to the beginning of the case, we were talking about follicular lymphoma. This is a comment on the case. The patient in the case presentation has follicular lymphoma, the second most common form of NHL in adults in the US. The neoplastic B cells mimic a population of follicular germinal center cells and thus produce a nodular or follicular pattern. While multiple nodes can be involved, extranodal dissemination is uncommon. The 14-18 translocation is characteristic of FL and causes overexpression of BCL2, an anti-apoptotic gene. Consequently, these tumors are slow-growing and accumulate cells for 7 to 9 years. Therapy in the age of rituximab is undergoing reevaluation in clinical trials, but most patients would be placed on rituximab. Thank you very much.